Good afternoon and welcome to Well Aware with Michigan Medicine. I'm Dr. Dee Finner, Chair of the Department of Obstetrics and Gynecology and the Bates Professor of Diseases of Women and Children and Professor of Urology. Today, our experts are joining me for about 45 minutes of panel discussion regarding women's health through the decades. We will address questions submitted in advance, as well as questions you may have during the event. To submit a live question at any time during this Q&A feature at the bottom of your screen. You can submit your questions by simply typing them in, and we will do our best to get as many as possible during our 45 minutes of panel discussion. In addition to our skilled panelists, it's my pleasure to introduce Soledad O'Brien. Soledad is an award-winning journalist, documentarian, author, speaker, and philanthropist, and she's the CEO of Soledad O'Brien Productions. Soledad is a thought leader who influences national conversations. She's also a fierce advocate for women's health issues, and we are thrilled to have her with us today.
Thank you for that kind introduction, Dr. Fenner. It is my pleasure to speak with you and your audience today. Throughout my career as a journalist and also as a documentarian, I've sought out stories that highlight the health of all people, but with a particular focus and spotlight on women's health. I've told the stories of the disparities in the maternal fetal health of Black and white women. I've given viewers an inside look at the ravages of the opioid epidemic, and I've devoted numerous episodes of Matter of Fact with Soledad O'Brien to the COVID epidemic. So we've been covering these stories. Why? Well, I believe that stories have the power to move us in ways that just pure data sometimes fails to do. I think there's nothing more empowering and sometimes nothing more difficult than talking about something so personal but so important, women's health. We owe it to everyone, women and men too, to fully understand not just those health disparities, but why they exist, what are the social determinants of health, and how to help women have a greater say in their healthcare journey, whether it's bringing a healthy baby into the world or talking about a struggle with cancer. Those stories aren't just important, those stories are essential. Today, the panelists will answer your questions about a woman's health over the course of her lifetime. Michigan Medicine is a pioneer in women's health, from its maternal fetal medicine and gynecological care to research on health disparities to the study and treatment of pelvic floor conditions, cardiovascular health, all varieties of cancer, transgender health, mental health, and much, much more. For those of you who are watching this webinar from Michigan, you're fortunate to have this leading provider of women's healthcare right in your own backyard. As I was preparing for this event, I was inspired by a recent story of a woman who was able to play 18 holes of golf again, thanks to the Michigan Medicine Ovarian Cancer Initiative, which successfully treated her cancer, but also the neuropathy and the joint pain she experienced. This approach to caring for the whole person and not just treating the disease is something that makes Michigan Medicine stand apart from many other large healthcare institutions. Finally, as you all know, we live in an age when a cacophony of voices in the news and on social media can obscure and skew information. So I encourage you to do exactly what you are doing today. Listen to the experts. And now I'll hand the virtual stage back to one of those experts, Dr. Dee Finner.
Well, thank you so much for that meaningful message, Soledad. Thanks in particular for emphasizing the importance of listening to experts when making medical decisions. This is always important, but never so more than during a global pandemic. Now I'd like to introduce our panelists to you. Joining us are Dr. Samantha Schoen, Assistant Professor of Obstetrics and Gynecology, reproductive endocrinologist, Dr. Anita Shelgakar, an Associate Professor of Neurology and Director of the Sleep Medicine Fellowship, and Dr. Jordi Triebwasser, Assistant Professor of Obstetrics and Gynecology. She's the Implant Medical Co-Director at the Birth Center of the Von Voigtlander Women's Hospital and an expert in high-risk pregnancies. At this time, I'd like to give our panelists the opportunity to tell you about their professional specialties before we launch into the Q&A session. So first we have Dr. Samantha Schoen. Please tell us about your work.
Thank you so much, Dr. Fenner. So again, I'm Samantha Schoen. I am a reproductive endocrinology and infertility specialist here at the University of Michigan. I predominantly treat couples with infertility, but also a range of reproductive disorders, such as PCOS and premature ovarian insufficiency. And I'm thrilled to be here today. Thank you.
Dr. Shelgakar.
Great. Thanks so much, Dr. Fenner. As you all know, I'm Dr. Anita Shelgakar. I'm an associate professor of neurology here at Michigan, and I specialize in sleep medicine. So in that capacity, I see adult patients of all ages and at all lifespan stages with sleep disorders. So difficulties falling asleep, staying asleep, or difficulties with excessive sleepiness during the day. So happy to join all of you today. Thank you.
Thank you. And Dr. Treibwasser. I think you're still on mute, Jordy.
There we go. Thank you so much for having us, and thank you everyone for being here for our webinar today. I'm a maternal fetal medicine specialist, so we take care of high-risk pregnancies, and other roles of the maternal fetal medicine specialist are to do preconception counseling for women who have either had complicated pregnancies or have medical conditions themselves. And another of my passions is taking care of women after they have high blood pressure disorders in pregnancy, like preeclampsia, and working towards better ways of getting those women into long-term health care.
All right. Well, thank you for the panelists. We're so excited to have you with us today. And thank you all who on the webinar for coming. We're fortunate to have these specialists who provide their expert opinions and advice on these subjects. My expertise is in the area of pelvic floor disorders and pelvic reconstructive surgery. These are really important areas that affect women's quality of life. And it's extremely rewarding for me to see my patients and work with them to find solutions so that they can then live their lives to the fullest. So now we're going to start to address the questions that come in. And I'd like to note at this time that the presenters cannot give any direct patient recommendations, but will be giving general advice. And again, if you want to put in a question, just please go to the Q&A and type your question, and we'll do our best to get those answered as well today. So here's our first question that was submitted. It's what resources are available to help women through perimenopause and menopause? And I think Dr. Schoen would be our best panelist to answer that question.
Yeah, thank you. Thank you so much. So I think there's sort of a number of questions about both menopause and the transition you mentioned, which is that perimenopausal period. Just to sort of clarify some definitions to start. So menopause is something that has to be sort of diagnosed retrospectively, meaning it's diagnosed after 12 months without a period. And then there's this transition period, the menopausal transition, also known as perimenopause, that on average, occurs about 4 years beforehand. And this is that period that's really characterized by increasing irregularity in periods, hot flashes, sleep disturbances, mood changes. And I think that this can be a really, obviously concerning time. In terms of looking for resources, the North American Menopause Society, known as NAMS, is a really great resource. They have a phenomenal website that has a lot of information sort of direct to patients and even information about books. And I think that can answer a lot of the really common questions about some of the experiences during menopause.
All right. Thank you, Dr. Schoen. The next question, there seems to be a knowledge gap around birth control. Women often need to try several before finding the right one. There's misinformation about the options and which are better for your body. Dr. Treibwasser, would you like to answer that question?
Sure. So even as high-risk OBs, we think about contraception a lot because we have patients kind of planning out their pregnancies. And contraception can be confusing, both because there are lots of options and because there's a lot of misinformation about which things are healthier. So there's no one perfect contraceptive method for anyone, which is why sometimes trial and error just has to happen until someone finds the best method for them. Some things we think about in terms of finding that best method include how effective the contraceptive is. So how good is it at preventing pregnancy? And things like IUDs and implants are the most effective methods, but it doesn't mean they're the right method for everyone. There are also non-contraceptive benefits of certain hormonal methods in particular. So for women with really heavy periods or who have acne or PCOS, there may be hormonal methods that help them with symptoms that aren't related to contraception. Cost should be less of an issue with the Affordable Care Act, but there are still access issues and insurance scheduling for things like IUDs that can be a little bit more complicated. And then the kind of from a counseling aspect, we like to get women's values involved and also use some non-medical websites to help them. So like bedsider.org is a really nice website that's very patient focused and goes through like infographics on here are the things that are important to me. Maybe this method would be the best method for me.
Thank you. All right, our next question is, I wake up frequently during the night and I'm not sure why. What should I do? Dr. Shelgakar.
Sure, I'm happy to take that question. Thank you. So when we think about sleep overall, we think about sleep quality and quantity. And so waking up frequently in the middle of the night can actually affect both of those parameters and can leave people feeling unrested or tired or sleepy during the day. And there are a number of things that can actually contribute to waking up frequently in the middle of the night. Things that may be related to the sleep environment, such as light, temperature, noise, and then other medical conditions, whether it's chronic pain, cardiovascular disease that may be associated with needing to get up and urinate frequently, or even other conditions such as anxiety, depression. And then separately, people may have coexisting sleep disorders in addition. So if you notice that this is something that you've been struggling with for a while, I really recommend that you go see your doctor about starting first with a medical evaluation and then deciding if needing to see a sleep specialist is a warranted next step.
Thank you. The next question says, nationally, there are threats to reproductive rights. Can you discuss what impact this would have on providing care for women? And how can we positively impact the politics around our rights? So I think I'm going to answer that question. Protecting reproductive rights and choice for women is a really a core value for those of us at Michigan Medicine and the Department of Obstetrics and Gynecology specifically. No one wants to do an abortion, and no one would hope that abortion would not be required. But in fact, abortion and the ability to obtain a safe termination is critical for us to provide comprehensive medical care for women. Every day here at Michigan, we can have a patient who may have a cancer that cannot be treated during pregnancy. She can have a heart condition that she may die if she continues a pregnancy. She can have blood clots, many conditions that can be fatal if not able to terminate that pregnancy. Other conditions may be that the the fetus is not formed correctly, that would never survive, and that woman and her partner, they should have a choice as how to manage that pregnancy. So we feel that it is imperative for women to be able to make that choice. And so right now, there's certainly the biggest threat that has ever been nationally since the passage of Roe v. Wade. We see new laws being passed in Texas, being now written in other states that would not allow a woman to have a termination if she was raped, cases of incest, again, conditions where she would die, if she may be infected and it's threatening her life. So we're very, very supportive and strong supports of women's reproductive rights. I think that, again, if you don't have to necessarily be pro-choice, but you have to be able to let the woman for yourself, but it's so important that women have that right. And so I say staying informed, making sure that you know what's happening in the state. We have laws here in Michigan that would, quite frankly, if Roe versus Wade would go away, that abortions would be outlawed. And it would be so difficult for us to care for women. So I think making sure that you know what's going on in the legislature, making sure you have contact with resources, making sure you know where your congressperson or your senator stands and how we can have influence. Certainly, Planned Parenthood is a strong voice for women, and other all conditions. They do so much more than abortion care, but they're a great resource for information so that you know, to know what's happening and how you can stay informed. So I hope that this becomes an important issue for everyone. This is not just for OBGYNs, but it's really all physicians, because we need to make sure that we rally behind and support women to be able to have the health care that they deserve. The next question is that recommendations for pap smears seem to change frequently. Could you go over how women should how often women should get a pap smear and until what age? I think Dr. Treibwasser, we have your name down for that one.
So if you're confused by this, you're not alone. Those of us who provide OBGYN care also have to refresh ourselves when these new recommendations come out. So pap smear recommendations have changed a lot, even in the last decade, really moving from something being an annual test to recognizing that if those pap tests, which look at cells to look for abnormalities or precancers, if those look normal, you can probably space to every 3 years. And that is a recommendation for women who are 21 to 29. It can also be a reasonable approach for those women who are in their 30s, 40s, 50s, and early 60s. An alternative method is using HPV or a viral test to help kind of assess how high the risk is of having a precancer or cancer. Those HPV tests are related to the virus that causes cervical cancer. So for women over 30, and in fact, the FDA approved it down to age 25, you can use HPV tests instead of or in combination with those cell pap tests every 5 years. Those recommendations are different if you've ever had abnormal paps or have had to have a precancer removed, and you kind of fall out of that low risk category. For women who have been low risk their entire lives or later in life in their 50s and 60s, you can probably stop getting PAPs at age 65.
Thank you, Dr. Treibwasser. Yes, indeed. The guidelines do change, and so it is for all of us to stay up to date. The good news is pap smears continue to be very effective in diagnosing early cancerous changes or precancer changes. So it's so important for women's health care. So I have a question now. Is the percentage of infertility among women increasing? What lifestyle choices can young women make to support their fertility for the future? This is for Dr. Schoen.
Great, thank you. So I think that one of the issues is there's a lot more awareness about infertility. So infertility is incredibly common. It affects 15% of couples. And I think one of the reasons we're sort of talking about it a lot more now is it's something that I think, years ago, there was a lot of taboo and people were sort of uncomfortable talking about their fertility struggles. There are some overall changes in lifestyle that I think may increase some risk of infertility. And, part of that is a general trend towards increased age at first birth. And age is such an important factor in the ability to get pregnant. In terms of what we can do early on to sort of assess our fertility, I think in gynecology, we often think of the period and the menstrual cycle as a vital sign. So I think that that's something even early on you can pay a lot of attention to. Having abnormal periods can be indicative of sort of other problems with hormones or other reproductive disorders. I think, in the past, a lot of times people say, oh, I have, irregular periods, I'll just start birth control pills without further investigating. So paying attention to that gynecologic vital sign can be really informative and helpful.
Thank you, Dr. Schoen. This next question is, I have difficulty falling asleep since menopause. Do you have suggestions on how to address this? For Dr. Shelgakar.
Sure, thank you. So when we talk about chronic insomnia, so if it's persisted for at least 3 nights a week for at least 3 months, then we definitely recommend behavioral strategies as our first line treatment. So things you can start doing kind of immediately are what we call sleep hygiene. So paying attention to keeping a consistent sleep-wake schedule. So waking up at the same time every day, going to bed at the same time every day, having a very consistent bedtime routine. So electronics are a big thing that can aggravate our sleep and can make it more difficult to fall asleep because of the light that's emitted from the electronics, and then potentially even depending on what you're reading or what you're doing on your device. So we recommend to put those away at least 1 or 2 hours prior to bedtime. If you absolutely have to use an electronic device prior to bedtime, then I highly recommend activating the night filter. Different devices call it by different names, but it's basically a filter that changes the wavelength of light that's emitted from your device and changes it from a cool blue or white light to a warmer red tone. And that's less activating for the brain and makes it more likely that you'll be able to fall asleep. In addition, keeping a cool bedroom for helping, again, that ability to fall asleep. Some people need room darkening shades to block out light, particularly in the summertime here in the Midwest when the days are so long and it can be hard to fall asleep when the light's still streaming in. And also having a quiet bedtime area as well. So if you try these behavioral approaches and they don't work, then that's when a medical evaluation may be warranted, either to look for another sleep disorder that may be contributing to your difficulty falling asleep, or even for cognitive behavioral therapy for insomnia, which is what's been shown to be most effective for long-term treatment of chronic insomnia.
Great advice. Thank you. The next question is, after suffering pelvic floor trauma and pelvic floor spasms dysfunction following the birth of my first child, 14 years later, I'm still suffering from significant stress incontinence. What could I do now that I'm in my mid-40s? So I think I'm going to take that question. So we know that roughly 10% of women will have some damage to the pelvic floor structures, the muscles, and some of the soft tissue at vaginal birth. Some of those will heal. Some of the women will continue to have either weakness in the muscles or may have spasm as a result of the muscle injury. We have many treatment options. Certainly, the muscles have to work well to help control the urinary leakage. And so my recommendation is to see an expert in pelvic floor, to have them evaluate to see if there's spasm still in the muscles. A spastic muscle doesn't coordinate or squeeze properly, or if there's weakness in the muscle. That can certainly happen after childbirth. Fortunately, we have many well-trained physical therapists who are experts in helping to retrain and to improve the function of the pelvic floor muscles. We have many here at Michigan Medicine, but we actually work with a whole cadre of physical therapists across the state of Michigan and beyond. So my first recommendation is to have an evaluation, see whether or not physical therapy is the right thing. For stress incontinence, we certainly have other things in terms of other surgical procedures, but we also want to try and focus on helping women to manage and heal themselves and then moving forward. The next question says, a lot of my friends are waiting to have their first baby until they're in their mid-30s. What should I know about waiting to have children until my late 30s or early 40s? So maybe we'll first hear from Dr. Schoen, and then we could hear from Dr. Triebwasser after that.
Great, thank you so much. I think this is a really important question. So to start, as women, we're actually born with all of the eggs that we're ever going to have. So you actually have the most eggs you're ever going to have when you're a 20-week fetus inside your mom's uterus. And then we see this decline that happens throughout our life. And that decline really picks up around 35 and 37. So what happens is we have a loss in the overall number of our eggs, but another really important factor is there's a loss in egg quality. So what this means is that in our late 30s and especially early 40s, the rates of infertility increase, it becomes harder to get pregnant, and we see a significant increase in the rates of miscarriage. Predominantly that's due to our eggs not working as well and not sort of getting rid of some of the extra chromosomes that need to be kicked out. Now, I think that the other thing to sort of consider is overall family goals. So if your goal is to have a family with 5 children, then I'd probably recommend against sort of starting to build your family in your late 30s. But if your overall family goal is to have, 1 child, then that may be a little bit less risky than the alternate situation. So of course, there's the impact of age on your ability to get pregnant and stay pregnant. And then Dr. Triebwasser can sort of talk about some of the risks during pregnancy, what we call sort of, advanced maternal age.
Sure, thank you. So there are kind of 2 different things that we think about in terms of our moms who are advanced maternal age or over age 35. And one is the risk of having a genetic problem with the baby. So the risk of chromosome problems like trisomy 21 or Down syndrome are higher. And really that increase starts around age 35, where we start to think of it as a more significant risk, and it goes up significantly for women in their 40s. We have ways both prior to conception using IVF technologies and testing to assess an embryo before implantation. And then we also have multiple screening and testing modalities during a pregnancy where we can test to see if a baby might be affected by a chromosome disorder. The other kind of bucket of things that we worry about as maternal fetal medicine doctors starts a little bit more for our moms who are over 40. And there are some health risks, most of which are not so severe that we would say, I don't recommend you get pregnant, but they are things to consider. So women over 40 have a higher risk of miscarriage, as Dr. Schoen said, but also of having a stillbirth. And so some physicians will recommend extra testing later in the pregnancy. The risk of developing preeclampsia, which is a blood pressure disorder, is higher. And so we recommend most of our moms over 40 take a baby aspirin to reduce that risk. There may be some increased risks of finding birth defects that aren't related to chromosome disorders. And the risk of having a cesarean delivery and gestational diabetes is also higher. So nothing that would say you can't have a successful, healthy pregnancy in your 40s, but it is different than a pregnancy in your 20s.
Thank you both. Okay, this is for Dr. Shelgakar. What are your thoughts on sleeping pills?
Great, thanks for that question. Sleeping pills, there may be a right place and a right time for them. For example, if you have really powerful seasonal allergies and that's contributing to difficulty falling asleep, using something over the counter to get at seasonal allergy syndromes and also be sedating to help fall asleep may be useful. So in those types of situations, for short-term situations, they may have a role. But we generally don't recommend using sleeping pills on a long-term basis. The research has shown that they're not effective in that capacity. And so, if you do feel that sleep is an issue for you and not just, based on certain circumstances or certain situations, then that's when a medical evaluation is really helpful, again, to look at all the factors that may be contributing to your difficulty falling asleep or staying asleep, and to see if there is, again, a medical condition that needs to be treated, a specific sleep disorder that needs a dedicated type of treatment, or again, if this is chronic insomnia that would benefit from cognitive behavioral therapy, which overall is much more effective on a long-term basis than sleeping pills. So I would certainly recommend that if you find yourself needing sleeping pills or using over-the-counter sleep aids more nights a week than not, I think it's time to get a medical evaluation to see what may be the underlying root cause there.
Thank you. All right, the next question. What determines who will benefit from hormonal therapy or other interventions for women dealing with postmenopausal hot flashes? Are there any non-medication options that are effective? So Dr. Schoen.
Great, thank you. So the most effective treatment for menopausal hot flashes is indeed hormone therapy. And hormone therapy can significantly improve those symptoms. Of course, that's a discussion that you have to have with your provider to sort of talk about the risks and benefits. There are a number of non-hormonal treatments as well. Some of these include things like SSRIs or SNRIs, gabapentin and clonidine. And then there are sort of just lifestyle changes that you can make as well. So, these can be things like having, keeping a cold glass of water by the bed, wearing lots of clothes with layering, avoiding triggers. So spicy foods and alcohol are all things that can sort of trigger hot flashes. There are other, you'll sort of come across other treatments like herbal remedies, acupuncture, and in terms of the actual data, the data is sort of mixed, and overall the most benefit is seen with sort of some of the medications, whereas the data is not as clear about some of sort of the supplements.
Thank you. All right, the next question is, do you feel that 6 to 8 weeks of maternity leave is sufficient for women's bodies to heal in order to return to work regardless of their occupation? Have you seen an early return to work contribute to chronic issues? I think Dr. Treibwasser, you want to try that one first?
Sure. So as a mom who has returned to work at less than 6 weeks, this is near and dear to my heart. I think we don't know from a health perspective the perfect amount of time to be out postpartum. Some women feel great 2 weeks after an uncomplicated vaginal delivery. Some women still have a lot of pain and difficulty with mobility 6 weeks after a cesarean that was performed during labor. And so, are you healed at 6 weeks is a little bit arbitrary because the kind of traumas your body goes through are different depending on how you delivered and just kind of how you heal. What is pretty clear is that the US is a real outlier in terms of supporting postpartum leave, not necessarily for maternal health, but for family health and economic security. And so really being supportive of legislation and companies that are offering longer leaves, particularly paid leaves, have been shown to improve child health is really important, but the maternal health benefits haven't been shown as much, but that might be because people haven't really looked. There's not a lot of information on how our leaves affect our health and how big that effect is.
I will add to that about healing of the pelvic floor, that we know that it can take up to 6 months for healing of the muscles and soft tissue. What we don't know for sure, is it better for women to have more pelvic rest, meaning not to exercise as strenuously or do heavy lifting or heavy work, or is it better for them to do that to help strengthen? And so we are doing a lot of research here at Michigan to try and figure out how we can best counsel our patients and how to know what is the right thing to do in terms of the pelvic floor healing for women after delivery. All right. The next question is, what is being done to address the tragic statistics around maternal mortality and infant death in Michigan and in the US? I guess maybe Dr. Treibwasser, do you want to comment on that? And I can talk a little bit about our efforts here at Michigan as a department.
Sure. So luckily, over the last couple of years, there's been a real public focus on maternal mortality, which actual deaths, but also morbidity, which is much more common. But we think if we can kind of find the reasons that the morbidity happens, maybe we can prevent those more serious episodes or actual deaths for our moms. And so some states have been very effective in helping to reduce morbidity. California has a maternal care coalition across the state, including most of their delivery hospitals, that has found some care bundles and areas to really focus on, like hypertension and postpartum hemorrhage, to reduce those life-threatening episodes. And they have actually shown that they have decreased morbidity in the last few years, whereas most states are finding more morbidity episodes. Illinois has done similar things. They showed decreased morbidity when they started treating blood pressure more aggressively in the hospital. And so I think a real key to those places that have been successful, and Michigan is rolling out many of those same bundles, is that you learn more when you work across health systems. So the places that are seeing real benefits have kind of big enough numbers to see how does this work in different populations, what really works, what's possible at different sized hospitals. But that's kind of one piece, is the how do we keep people safe in the hospital right around time of delivery. But that is not actually where most women are dying after childbirth. So the 6 weeks to 12 months period is actually more dangerous and gets very little attention. Some states have applied to get federal funding to expand Medicaid. Instead of ending at 60 days postpartum, that it would last a full year. It's about half of the states that have done that. Michigan is not one of them as of now, but that could be a real game changer in terms of like heart deaths that happen in the year after delivery and substance abuse deaths. Those are really driving some of the changes depending on what state you're in, and being able to support our moms with full health services that don't get fragmented after delivery is really, really important.
Yeah, thank you, Dr. Treibwasser. So we here at Michigan, we are doing a lot of work first in our own labor and delivery unit of the Von Voigtlander Hospital. We do use those bundles that we talk about. What that means is that there's a set of questions that the patient gets asked, a set of tests, a set of information about her delivery that we everyone assesses the same way, and that we aggressively treat the blood pressure or make sure and look at how much bleeding she's had, so that we can certainly in our patients provide the absolute best quality of care. On the state level, we're working with the organizations. We're in Region 9 of a Michigan groups supported by the Michigan Hospital Association and the Department of Social Services, and we've been a leader in trying to organize around the state so that it's just not in Ann Arbor, but certainly regardless of where women are pregnant and where they're delivering, that we can try to have the same quality of care across the state. So we feel a very strong obligation to really care for and support all women. We also have involved in the policy, as I mentioned, the ability to extend Medicaid so that women have coverage for longer than just a few months after delivery. And so we are very active and we're working with the legislature to try and work with policy changes. We work a lot with Blue Cross and Blue Shield Insurance and Equality Collaboratives to try and help again, have the right coverage. And then I guess I will say one thing that's been shown really is important is that physicians and midwives and all healthcare providers actually listen to women. Because we know that most of these deaths are preventable, and that the patient herself said, I didn't feel right. My head hurt because my blood pressure was so high, but really weren't taken seriously or didn't have the right resources. And so really campaigning and making sure that we take women's voices seriously so that when these things happen, that they are listened to and they're immediately seen and taken care of. So it is a national crisis and embarrassment for us. If you, in fact, it's a tragedy. If you look at other third world that are under-resourced countries are doing better than the United States. So if they can have better care in Uganda or some other countries, my goodness, surely in the United States and in Michigan, we should be able to do better. So it's a really important question. So I thank whoever asked that question. All right. So I have a question is that when should someone be tested for CPAP? How do you know if you have sleep apnea? And maybe I think that is so obviously for Dr. Shelgakar. Could you talk a little bit about the apnea and how that can impact someone's sleep and energy, et cetera?
Sure. Thanks for that question. So obstructive sleep apnea is characterized by repeated episodes where the airway either partially or completely becomes blocked, which either causes the brain to wake up briefly from sleep or causes the oxygen to drop by at least 3 points. And this happens repeatedly over the course of the night. So sometimes people will put in their due time and be in bed for, what they feel is the right number of hours for them, but still wake up feeling very unrefreshed and then have sleepiness during the day because they're not getting full consolidated sleep because their sleep is constantly broken up by these apneas. So there are some screening questionnaires that we can give when patients come into our clinic, but the definitive way to diagnose obstructive sleep apnea is either through a home sleep apnea test or through an in-lab sleep study. So again, having a medical evaluation either with your primary care provider or in a sleep clinic can be a good starting point to get that evaluation going, to have one of those diagnostic tests done to see if you do have obstructive sleep apnea, And then there are a number of treatments available, CPAP, continuous positive airway pressure being the gold standard treatment, but there are various other dental treatments and surgical treatments and a few other non-surgical treatments as well that we can offer for the right person, depending on the factors about their sleep apnea and their other medical history.
Thank you. It says, what can I do to support the health of my teenage daughter now that will help her as she ages? No, Dr. Schoen, can you answer that?
Sure. So again, great question. I think, partially instilling those things early on that we know are important for general health. So, establishing healthy eating habits and exercise and adequate, calcium and vitamin D intake. And then again, being comfortable, again, talking about, I'll come back to the menstrual cycle because I love it so much. But again, if she's having any irregularities or problems with her periods, it's something to talk about and bring up. And I think, it's important to have a good relationship with your gynecologist early on. There are certainly things that can put you at risk, at least for fertility issues later. So example, education about sexually transmitted infections, things like gonorrhea and chlamydia, can cause significant fertility issues later in life. And so certainly, preventing those sorts of infections, same thing, herpes can have impacts during pregnancy as well. So I think, being comfortable to have some of those conversations that are uncomfortable, but can have a significant impact later.
Okay, thank you. So this is, what risks for cardiovascular disease in women who have preeclampsia? So Dr. Triebwasser?
Sure. It's a really great question because preeclampsia is really quite common. It affects about 5% of pregnant women. And what research, particularly in Europe, but we've seen it as we've gotten bigger data sets here in the US, is that women who have preeclampsia are at much higher risk of developing high blood pressure or hypertension. And that can happen within 1 to 2 years of their pregnancy. So about 40% of women will end up having hypertension within 2 years of their pregnancy, complicated by preeclampsia. And within 10 to 20 years, you see a significant increase in the risk of other cardiovascular disease, including like strokes, arrhythmias, heart failure. For women who had kind of the most severe forms of preeclampsia, like preterm preeclampsia, you can even see some of that heart disease within a year or two of delivery. So it's really, really important, one, that we as physicians and midwives share the diagnosis with our patients and don't just kind of know it in our heads. Let them know what's affecting them and let their primary care providers know that too. We really need to be using OB episodes as kind of an entry into lifelong care and stop thinking of it as just kind of this siloed event, because so much of what happens during pregnancy is kind of a window into what's going to happen to that woman later in life. So kind of being aware of your diagnosis and taking preventative steps that you can of maintaining a healthy weight, moving more, don't smoke if you smoke, and get help with quitting if you can. Those are really helpful for heart health, and particularly in those women at higher risk.
Thank you. There's a question, could you discuss current and future screenings for ovarian cancer? So we know that ovarian cancer, while it's like the 5th most common cancer in women, it is one of the leading causes of death. The reason for that is that it's most commonly diagnosed when it is what we call it a stage 3 or stage 4, meaning it's gone beyond just the ovaries and it's spread throughout the abdomen into the liver or lungs or other organs. And so it is definitely a serious concern for women as we get older. About 1% of women without any genetic predisposition will get ovarian cancer. It's unfortunate that at this time, despite lots of research and studies, that we really have no good screening tests for ovarian cancer. The tests we have, like routine ultrasounds, either every year, every other year, or any blood tests that would pick up a marker for the ovarian cancers, have not been shown to be effective. And in fact, they actually do harm, because you see little cysts, or you may see things on the tests that cause a woman to get a surgery that can have complications. And it has not been shown to pick up the ovarian cancer early, and it has not been shown to actually change any of the mortality associated with ovarian cancer. So while that's sort of the disappointing thing at this time, there is a lot of work being done trying to find a marker that would diagnose the cancer early. I think there are some exciting new innovations in this area that hopefully we will see in the next 3 to 5 years, and ways for us to make better diagnosis. We do know that certainly if a woman is having a surgery for other conditions, say she has pelvic organ prolapse, or she's having a hysterectomy for bleeding, that it's really important to remove the fallopian tubes, because we know that a lot of the ovarian cancer, it actually starts in the tubes. And so that's been a change that we think will save women's lives. But overall, we wish you had better screening right now, but we certainly hope in the not too distant future that we'll have ways to help women to have an earlier diagnosis. All right, let me see. There's a question that says, how do you respond to a young woman who's worried about her fertility if they get the COVID vaccine? And perhaps we could also talk about with Dr. Schoen, and then maybe Dr. Treibwasser could talk about the COVID vaccine and pregnancy.
Thank you. So we are encouraging all of our patients to get the COVID vaccine right now. And we have several studies that provide very good information that the COVID vaccine does not at all impact fertility. So at our office, we're encouraging all of our infertility patients to get vaccinated. And again, there have been several recently released studies that are provide very convincing evidence that this vaccine does not impact fertility.
And
we've also moved with the data from an OB side, where when the vaccines first came out, ACOG, which is one of our national bodies in the Society for Maternal Fetal Medicine, were pretty cautious and said, talk to your doctor, depending on your risk factors, maybe consider vaccination. And the more data we get, the societies have really moved to say, we're kind of past that. We're flat out recommending the vaccine, both because we've seen vaccine safety and because with time we've seen that COVID really is more dangerous for pregnant women than from their age-matched non-pregnant controls. So if a pregnant woman gets sick with COVID, she's more likely to go to an ICU. She's more likely to end up on a ventilator. She's more likely to die than someone her age who is not pregnant. And if a vaccine can prevent severe illness, it's good for mom and baby. The other kind of exciting part about vaccination during pregnancy is it may be your one opportunity to protect your baby, because we have seen that antibodies cross the placenta and can be detected in cord blood. And so the only way to get your baby some immunization is to get yourself immunized during pregnancy. And the second trimester is probably the right time, even if you didn't get vaccinated before pregnancy or in the first trimester.
great, thank you. There's a question about postpartum sleep with a baby. Do our bodies suffer from sleep disruption due to the newborn feeding needs, or do our hormones help us, I guess, in protective? So Dr. Shelgakar, do you have some thoughts on that?
Sure, absolutely. You know, the body obviously is going through so many changes, not only biologically, but even then the surrounding environment and the routine is, you know, entirely disrupted after childbirth. So all of those influences can impact your sleep in the postpartum period. There's some data to suggest that breastfeeding may actually help us help the brain go into deeper stages of sleep, and so may be conducive to sleep. But then again, there's the balance with the repeated wakenings for feeding. So there are some things that are kind of balancing there that contribute to overall sleep. So we definitely have recommendations for pediatric sleep. Once babies are a little bit older, when they're in that immediate newborn age, it's hard. Their sleep schedules aren't organized yet, and their sleep is, you know, they tend to sleep a lot during the day and maybe up more at night. But as that regulates over time, having a more concrete structure, just like we talked about before, for adults is even helpful for infants and toddlers, and can be helpful with getting the family back to sleep.
All right, thank you. So I think we're going to move to our last question, and maybe we can start out with Dr. Schoen and then Dr. Treibwasser and then Dr. Shelgakar, and we'll all maybe take a chance at this one. It is, what can women do to improve their overall wellness as they age? Dr. Schoen.
Great. So again, I think that, you know, there's some things that are important throughout life, right? So those are the things you hear us all talk about in terms of diet and exercise and drinking plenty of water. And then, you know, I think there are needs that change as we age. There's particular health risks that change as we age. So, you know, predominantly, I see women in their 20s, 30s, and 40s who are thinking about pregnancy. And at that point, you know, we're focused on supplementation and sort of overall fertility. But certainly later upon that menopausal transition, thinking about the other risk factors that become much more apparent. So risk for cardiovascular disease and the risk for bone decline that risk really increases at that menopausal transition. So at that point, you know, focusing on making sure you're following up with your PCP and are up to date with sort of testing for risk factors of cardiovascular disease and making sure that you're getting plenty of intake for calcium and D. So, yeah.
Great. Dr. Treibwasser or Dr. Shelgakar, do you have a few parting words?
Yeah, so I think move more and eat moderately is probably the simplest and maybe sometimes hardest advice, but benefits people at all life stages. And I think the other thing to keep in mind is, like, you know your body best. And so if things seem like they're not right, to ask questions and go see someone. And that is true for pediatrics, where I think we as parents really look out for things that aren't typical, but we need to treat ourselves that way too in adulthood.
Thank you. And Dr. Shelgakar.
So thanks for the question. I'm obviously going to answer this through the lens of sleep. I think it's something that we in our societies and with multiple responsibilities that we all take on, that sleep is sometimes the first thing that gives, sometimes for short periods of time, sometimes indefinitely. And it really is vital to our overall health. So the recommendations for adults are to get at least 7 hours of sleep per night, every night. And so to allow yourself the opportunity to sleep, that it's not being selfish, it's not being dismissive of other things, but it really is a way of tending to your health.
Great. I have a few words. Do your Kegels. How's that? All right. So first of all, I want to thank all of our panelists and viewers for tuning in. Thank you for joining us today and your engagement and interest in women's health. Your questions were great. We tried to get through as many as we could. I know we didn't get through them all. We hope you found this session informative and you learned some things that might be applicable to your lives. As a reminder, a recording of the webinar will be sent and a follow-up email to those who've registered, including a link to support our Women's Health Innovation Fund. We hope you'll consider contributing to this effort as our faculty and staff work really hard to provide outstanding care. And also wanted to share that in next spring, we'll be hosting our first annual Women's Health Luncheon. We're excited to gather on April 27th of 2022 to raise awareness and funds to benefit women in Michigan and beyond. If you're interested in joining us, please sign up for more information using the link in the chat. So the next Well Aware with Michigan Medicine webinar takes place on October 14th. You can expect an invitation emailed to you in a couple of weeks. So please stay healthy, stay safe. Thank you, and go Blue.